Welcome to the ICU Emergency Care and Critical Care Module 2. I'm Maya Yadam. I'll be the moderator for this session here with two other speakers who you'll get to meet shortly. Today, our focus topic is including machine learning to enhance patient safety and quality for emergency and critical care. And I'll go ahead and share my screen to get ready to start our first presentation. And so it's my pleasure to have this discussion and to meet with you all to talk about a framework for artificial intelligence in emergency medicine. As I mentioned, I'm Maya Yadam. I'm an associate professor and the vice chair for research for the Department of Emergency Medicine at Stanford University. And this work that I'll discuss with you and sort of walk you through has had me working shoulder to shoulder with nursing in emergency medicine, as well as informaticists, statisticians, machine learning experts, health IT engineers, as the person who's providing the use case where all of us are bringing our skills to be able to solve a clinical problem and achieve what is ultimately our final end product and our desired common end product, which are better patient outcomes. Now, I'll say that when many of us are thinking about artificial intelligence in medicine, we picture a sentient being who has been programmed to capture all the knowledge that we've acquired from years of study, the experience that we've gained from bedside care, and the lessons we've learned from all of our successes and failures. And there's generally an air of excitement. However, there's also a little bit of skepticism that our practice, which is part science, but also part art, can be replicated in this way. So I think the sentient being takeover in medicine is probably light years away. However, there's still opportunities for artificial intelligence or AI in emergency medicine that are right to make our jobs easier and also our role in healthcare delivery much more effective. So you can actually replicate, you can introduce artificial intelligence without competing with physician expertise. And this is often seen to be, it's often seen that artificial intelligence replaces the human, and that does not need to necessarily be the case. In fact, it can be used to offload the mental load of trying to consistently replicate a decision the same way for different kinds of patients under different conditions and different scenarios, when there are common denominators that are sometimes hard to parcel out within your typical live care due to human error and human variability. And then lastly, it empowers us to introduce complex physician-like decision-making into phases of care where physician involvement is not optimal. And so we'll talk a little bit more about this, and I'm going to ask you to explore with me a much more fundamental conceptual perspective on artificial intelligence, where we'll talk about it as being the use of computer systems to perform tasks that normally would require human thinking, calculation, and action. And so this really involves a linkage of 4 critical steps that extend from codifying the knowledge that we use to make a decision to having a computer initiate action that automates decisions that we would have otherwise been doing ourselves. So let's walk through these 4 steps just for clarification and for illustration purposes. The first is to really understand the decision that we're looking for a computer to help make. This involves research investigating variation in decision-making to identify the critical data needed to come to a conclusion and the context in which it's made. And this space is really filled with evidence-based medicine, many different phases of it to really understand the full circle, this aspect of how we make decisions. That data, that critical input data, then needs to be synthesized. And this is what's referred to as the logic model. So it's often an algorithm that replicates the thinking that is used to make a decision in medicine to practice with the creation often of decision rules and pathways. And we're all pretty comfortable and have used these often in our day-to-day practice. What really gains us efficiency is having a computer help us to do the work. And often with the use of a decision calculator, which again, many of us are familiar with MedCalc or MDCalc or many other calculators available to us to take what we know about a patient in the moment to help us balance potential diagnoses in a differential diagnosis, or the likelihood of a particular diagnosis being what they need, or treatment being effective, or test being warranted. However, the real critical step in translating this exploration of our practice and efficiency in being able to synthesize information on our own is to allow a computer to initiate action based on the decision outcome from that calculation. And this is really the next frontier. So if you think about it, there are many scenarios where we have fairly routinized ways of approaching practice that we strive to execute the same way every time, but are often distracted or don't find the opportunity in the day-to-day that leads to variation in practice. or inefficiencies in not being able to do it the smoothest and earliest way possible. So if you think about this, there are many opportunities in emergency medicine where, for example, if you had an older patient who came in with a history of coronary artery disease, a myocardial infarction in their chart, with chest pressure or shortness of breath or dizziness, very similar to when they had cardiac issues before, there's a set of tests that they're not leaving the emergency department without having that likely include a troponin, some other basic blood work, an EKG, maybe a chest x-ray. Or you think about the young woman of reproductive age who comes in with vaginal bleeding. There's probably not a chance she's leaving the emergency department without an HCG and some other basic blood work, as well as a pelvic exam. So preparing for those things early increases efficiency and doesn't need to be a replicated thinking process. And so we've already made this transition to realizing that thinking about this de novo every time is perhaps not efficient, with the common use of nursing protocol orders based on chief complaints that patients present to upon arrival. And what we ask is if future patients didn't have to wait for a nurse to initiate orders that are already protocolized, but rather the protocol orders went in and were modified by nursing. That way there was never this opportunity to miss having care initiated in a timely fashion. We probably would make progress, but it would need to be dependent on some really robust work to parcel out what is truly needed by a patient based on what we know about them in early stages of care. And so I'll give you an example of how this really plays out in some of the work that I do related to ST elevation myocardial infarction. This is an area that's well studied. We've had clinical guidelines for over 30 years, hospital quality metrics for over 20 years. It's very life-threatening. Mortality increases in the order of 7.5% for every 30 minutes of delay, so every minute matters. Physicians and nurses are trained on how to identify patients who need early testing. And in addition to this, we're all targeting trying to get a diagnostic test and EKG done in 10 minutes. And there are metrics for doing this we all adhere to and are tracked nationally. But the way that we do this is maybe not optimal, and there is an opportunity to improve this that can use the power of the computing that's now part of our practice. And so just to illustrate what we're trying to do to highlight where the opportunity is, when a patient walks in, they're either walking in the front door or rolling in via an ambulance with an EMS or paramedic team. They're encountering typically a clerk, but sometimes a nurse, less likely a nurse on arrival. And our goal is to get an EKG in 10 minutes. There's no physician involved in those early minutes of arrival. So there are protocolized and pre-specified criteria with which to initiate an early EKG, often before they've been transitioned to a bed. And that EKG is then taken to a physician who, based on looking at it first before the patient, if it's concerning, will go and meet the patient. With the objective that if this does look like a STEMI, the cath lab is activated and the patient is in the cath lab getting intervention within 90 minutes. And this is our ideal scenario. And so you can see that STEMI is a very rare condition. I think the incidence is 0.001. So having a doctor at the front door waiting for the STEMI patient is probably not the best use of resources when other emergencies are occurring with higher frequency. So we took a look at national data and saw that everybody's meeting the metric to get their times within 10 minutes, but we track based on medians. And when we took data from high-performing centers across the country, we saw that the median was 7 minutes, even the interquartile range was quite impressive and not too bad. When we looked at the proportion of patients who were above that target, it was more than a third. And so this was concerning that more than a third of patients with the true disease we're looking for were not getting this early test in a timely fashion. And we looked at what was happening practice-wise. So what we found is that most emergency departments didn't have formal screening for folks presenting with potential STEMI. It was left to the discretion of the folks who were in the front end. And again, if I can remind that often the first person is a non-clinician who reliably contacts the patient in 10 minutes. And 14% use chest pain as a sole criteria, suggesting 30% of sites don't have adequate screening. So we looked at some of the more robust criteria you can see here on the left. And as much as there are lots of details here, when you really boil it down, there are two criteria considered: age and chief complaints. So we said, well, maybe that's robust enough. But when we looked at performance, we found that when we looked at folks who had STEMI, and we actually looked at those who screened to get their early EKGs on time, our sensitivity for capturing them for an early EKG was only 71%. So if you're trying to convince an ED that uses, say, chest pain only, that doing more is better, that modeling to create more detail is better, you can see here that chest pain alone has an AUC of 0.83, which is pretty good, but not for a life-threatening condition. And that by adding criteria with additional chief complaints and then adding age, our AUC markedly improves. But we're really trying to get it to be here 100% or 0.0 or 1.0. So this is where machine learning can really add to help us to get that high sensitivity, to be able to capture each patient with a STEMI and differentiate them from those who do not. And so there are many areas in medicine that are emergency medicine that are emerging where interdisciplinary partnerships with biomedical informatics specialists in the growing community of applied clinical informaticists is elevating our ability to explore applications of AI in our care space. As I mentioned, identifying the rare patient with a STEMI using past medical records, registration demographics, and chief complaints sounds simple, but far more robust than what's happening. There's also work analyzing variation radiological imaging to identify abnormal findings with specific work on pulmonary embolism and identifying cancers, potentially cancerous nodules. And lastly, there's strong work happening with predicting elderly patients with features predictive of traumatic falls. So more to come, but I ask all of you to think broadly about whether there's opportunity to introduce artificial intelligence into your own care environments. Next, I'd like to introduce Dr. Daniel Ehrman. After completing medical school and a master's degree in clinical research at the University of Michigan, Dr. Ehrman went on to complete a categorical pediatrics residency and pediatric cardiology fellowship at the University of Colorado. He's currently a first-year pediatric critical care fellow at the Hospital for Sick Children in Toronto. His academic interests include the broad drive to make sense of dense physiologic data generated from critically ill children in a way that leads to actionable insights for clinicians and improved outcomes for patients. He's currently developing expertise as a clinical lead for applied machine learning and data visualization projects. He currently lives with his wife and daughter in Toronto, so I am pleased to introduce him as our next presenter.
Thank you very much, Maya. My name is Dan Ehrman, as previously mentioned, and I'm one of the Pediatric Critical Care Fellows at the Hospital for Sick Children in Toronto. I want to talk to you about making machine learning matter, presenting a framework for model actionability at the patient's bedside. I'll start with an analogy. If you look at this picture of the Royal Gorge outside Canyon City, Colorado, I think it presents a nice analogy for where we're at with machine learning in healthcare. I think there's a chasm between the models that are developed in silico and the models that make it to the bedside in a way that actually improves patient outcomes. And I think one of the main reasons for this is that this is the environment in which clinical decision-making occurs. As you can see, there's many different sources of patient data. The data can be riddled with uncertainties and contingencies and inaccuracies. And it's in this environment that we need models to perform well for clinicians, but most importantly, patients. And I'll propose that clinicians need applied machine learning to augment insight in a way that directly facilitates clinical decision-making. In short, clinicians want models that are accurate, but also actionable. And I've highlighted also here because I'm not proposing that the current framework in place to evaluate models is wrong. I'm just proposing that it's incomplete. And so that in addition to an F1 score, something like this, we also need a framework to evaluate actionability. And so as we think about this framework for actionability through the lens of clinical decision-making, how will we design this? So in a perfect world, what we would do is actually just deploy the models at the bedside, perform a randomized controlled trial, and try to understand how these models impact decision-making and outcomes at the point of care. But given that randomized controlled trials are difficult to perform and there are limitations in the resources available, we need a pre-deployment framework for actionability to allow us to understand which of these models would actually be likely to be helpful at the point of care. And as we think about this, I want to emphasize that these metrics would be in addition to standard metrics of model accuracy. And so one way that you might conceive about a model for actionability is through this familiar example of a partially observable Markov decision process. And so like any Markov decision process, the agent, or in this case, the clinical decision maker, moves a patient from an actual current state to an actual future state through chosen action. Now, I want to emphasize that the clinical world is partially observable because rarely do we know the true underlying state of the patient. We have actually instead observed clinical data. And based on the observed clinical data, we inform a belief state about what the underlying state is likely to be. And then based on that, we choose the action and how to move a patient forward. And one of the advantages of using the POMDP is that it allows me to introduce the concept of entropy. So entropy is a concept from information theory that basically tries to quantify the average level of an uncertainty for a given variable's outcomes. And so using this simple example, I'll draw your attention to the x-axis, where we're talking about the probability of obtaining an outcome that we'll call a plus. So assume the options are either you get a plus or a minus. And if the probability of the plus is very low, let's say 0, or the probability of obtaining the plus is very high, let's say 1, the entropy associated with that situation is minimal. But instead, if the probability of obtaining a plus is unknown, so for example, if it's 50%, then the entropy of that situation would be maximal, in this case would be 1. And that becomes relevant because I'll propose that actionable machine learning decreases entropy at high entropy phases of medical decision making. And I'll try to illustrate this in the slides to come. So going back to our POMDP framework, let's focus on the phase of diagnosis where the entropy can be high. So by way of example, imagine a patient comes in with shock, defined as the inability of the body to deliver oxygen and nutrients to the tissues. Now, in this situation, shock can be caused by heart failure, by vasodilation, by low blood volume, etc., a variety of true underlying states that I've indicated here as S1, S2, S3, S4, and S5. Now, as you think about those true underlying states, the clinician doesn't know what the true underlying state is, so he or she relies on clinical data, and based on that clinical data, develops a belief state or a differential diagnosis list about what is most likely to be going on with the patient. Now, in situations where the observed clinical data yields a belief state that is quite uncertain, the entropy of the probability distribution associated with the current state can be quite high. However, in situations where the data that is generated is quite certain, then the probability distribution of the current state can be quite low. Now, what's most important here is that actionable machine learning allows the clinician to go from a high entropy distribution to a low entropy distribution. And in so doing, increases the certainty of the clinician as to what's going on, and therefore what action would be most likely to be beneficial to the patient. I'll also propose another point in the clinical decision-making that is associated with high entropy, which can be deciding what to do for the patient. So when we think about actions at the bedside, I'll propose that there's really two different types of actions that we take. There's treatment actions, which are actions that are primarily intended to move a patient from a current state to a future state that's more desirable. And then there's information gathering actions. And this becomes particularly relevant if we think about the clinical environment as a POMDP. The information gathering actions are designed to gather information in the form of clinical data that increases the certainty to the clinician about what the true underlying state is. And I'll talk about a couple of examples here. So let's talk about a treatment action. So imagine a scenario where a clinician has developed an abnormal heart rhythm after cardiac surgery or an arrhythmia. Now, in this situation, assuming that the clinician has a working diagnosis or the most likely diagnosis in their opinion, they may be able to treat the patient by choosing the action of no action, by choosing the action of non-pharmacologic treatment, or by choosing pharmacologic treatment. And imagine that the clinician has decided to institute pharmacologic treatment and has the option of 3 different medications to choose. Now, when the clinician decides to treat with this medication, one of these 3 medications, the outcome of that is unknown. The patient's heart rhythm can terminate, it can change, or it can devolve into a more unstable arrhythmia. And that's what's illustrated here by S1, S2, S3, etc., for the possible future states. And in situations where it's not clear the probabilities of those potential outcomes for each of the different medications, it can be especially challenging to choose the right medication for the patient. So actionable machine learning would recommend the action, or in this case, medication, that's associated with a decrease in entropy of the future state probability distribution. And the maximal decrease in entropy offered by each of those medications can inform which of the medications is the best choice for the patient. Remember that I talked about that there were two different types of actions. This type of figure shows the information gathering action. So going back to our patient with undifferentiated shock, the clinician might decide that they're still unsure based on the observed clinical data about what's going on, and therefore might pursue additional investigations or choose the action of getting laboratory tests to generate new clinical data that informs the belief state in a way that transitions the patient from a high entropy distribution to low entropy distribution regarding their underlying current state. But I want to highlight here that deciding which laboratory investigation to obtain, for example, is unknown. Some of these laboratory investigations will be helpful, some of them will be not helpful, and some can actually be harmful. So actionable machine learning will recommend which of the laboratory tests to obtain that can generate a new set of observed clinical data in a way that will maximally decrease the entropy of the underlying state distribution in the eyes of the clinical belief state. But you'll notice that in that situation, the underlying current state doesn't change. There are some types of information gathering actions that are actually associated with changing the underlying current state to generate new clinical data that is helpful for the clinician. So going back to the example of undifferentiated shock, sometimes when a clinician is not sure about what the underlying cause is, they might decide to give a small bolus of IV fluid. And based upon how the patient reacts to that, that might clarify what the underlying diagnosis is. So for example, if they respond favorably, it's likely that they're in hypovolemic shock, for example. And if they respond unfavorably, they might be more likely to be in cardiogenic shock. And in each of those circumstances, the clinical data that is generated from the underlying state informs the belief state in a way that decreases the entropy of the probability distribution of the future states. Now, I want to be clear here that the action that's chosen to do that can be unknown. It's unknown, for example, what type of fluid to give, how fast to give it over, those types of questions. And so actionable ML would provide answers to those questions in a way that maximally reduces the entropy of the future state probability distribution by generating useful and new clinical data. So I've talked a lot about actionability as a theory, but I think it's important to also translate this actionability concept into something practical, which is an actual calculation of actionability. And so how might we do this? So let's take the example of the treatment action that I talked about earlier. So like any MDP, the variables at play here are state, action, and since we're dealing with a partially observable MDP, observations. And there's a policy here that basically is the recommended action given that you're in a particular state at a particular point in time. And so we might calculate that there's a clinician policy that is not using machine learning that basically recommends an action that through some transition probability matrix results in the probability of a future state. Now, you might also do the same exact exercise with a machine learning model. And since these probabilities are part of a distribution, you can calculate the entropy of the probability distribution for each of the models. And so actionability would be the degree to which the machine learning model decreases the entropy relative to the clinician policy. And if you come up with that metric, you can imagine a scenario that's associated with measuring actionability of different models to figure out which of them is more actionable and ready for deployment at the bedside. I think there are important assumptions and caveats here. I'm talking about actionability being applied to machine learning models in healthcare. I acknowledged that there's a risk of oversimplification, that at the bedside, it's not as simple as taking one action translating to one future state. In reality, the actions that we do at the bedside are sometimes associated with sub-actions, or we do multiple actions in quick successions. And then I think there are theoretical components here as well. So for example, the transition matrix that I spoke about in the calculation slide, that would have to be something that is empirically derived, ideally with clinician input. So I want to leave one take-home message. If you don't remember anything else from my talk, it's that measures of model actionability should be reported with other traditional metrics of model performance to make machine learning matter at the bedside. And as we think about the implications here, though actionability should impact decisions around model deployment, perhaps more importantly, it should impact decisions about model development. As I spoke about previously, RCTs are expensive, and so it's helpful to know if a model is actionable, i.e. ready for deployment and justifiable to invest those resources versus not. But I think even more importantly than that, we should think from the very beginning which problems in healthcare are associated with high entropy. And if clinicians work with computer scientists to define the problem correctly, then we're more likely to develop models that have actionability almost built in. And so I'll return to a picture of the Royal Gorge. And as you can see, almost 120 years later, this gorge now has a bridge over it. And I think this is an inspiring update to the analogy. I view actionability as the bridge that we must travel together to move models from in silico development to being helpful at the bedside. And I think only by doing that can we end up with models that impact clinical decision-making and improve patient outcomes. Thank you very much.
Our next presenter is Dr. Chris Laudansky. He's an assistant professor in the Department of Anesthesiology and Critical Care at the University of Pennsylvania. His research interests focus on regulating DNA expression in survivors after critical care illness, healthcare operations, medical decision-making processes, and healthcare innovation, specifically with expertise on artificial intelligence and nanotechnology. He's a principal investigator on the NIH-funded project and a founder of a startup company, Bin Diagnostics, since his research shows that suboptimal decision-making processes might expose patients to unnecessary risks and have negative economic consequences for hospital systems. He suggested, developed, and implemented artificial algorithms in critical care settings. Dr. Laudansky is particularly interested in integrating artificial intelligence algorithms in wearable devices, predictive medicine, and alternative healthcare delivery models. Adjusting healthcare operations and delivery based on available, culturally specific, and local demands is another area of interest that he frequently pursues in austere and remote environments. He's been a mentor, believing that mentorship is creative and fulfilling work to maximize students' potential, and his past mentees work in a variety of academic positions, private companies, and have been awarded prestigious scholarships. So it's with pleasure that I introduce Dr. Chris Laudansky.
Thank you very much, Maya, for this way too kind introduction. Let me share my screen and let's start from introduction. So again, thank you very much. I'm going to present over here some of the work that was done in the various institutions, but mostly at University of Pennsylvania, Princeton. And what I very much focus on is how you can actually harness the artificial intelligence to the benefits of the critical care. And I think that area is particularly safe to use in the terms in terms of identifying the potential barriers. So let's just go on with the presentation. So I have to do a couple disclosure. I'm NIH funded. I was funded also by Society of Critical Care Medicine. I am owner of the company called the Bin Diagnostics, and occasionally I consult for TrialX. I'm also president of SFCI. So all of this has no impact on my presentation. So let's talk about my work first. So I'm sure all of you did a rotation in ICU, and what can you tell about that environment? Well, it's horrific, right? You walk into the unit and you have a gazillions of the monitors, gazillions of the equipment. You have a multidisciplinary team, which God bless multidisciplinary of the team. But the problem is it's a big team to manage. People come and go. Everybody deliver the information. Sometimes those information are correct. Sometimes those information are not correct. So it's a really, really tough environment to work in the terms of the cognitive load. So, summarizing all of this together is it's a highly technical environment. You really need to know what you're doing because you have to use the equipment, which is complex. The environment itself is complex. You have a multiple stream of information with a different data veracity combine together, and then you have to sort of make a sense which of this information are true, which of this information are not true. It's a relatively unforgiving environment. Mistakes in the ICU are very, very costly, and quite often our mistakes are visible in the matter of minutes and seconds. It's a demanding environment. Not only the fact that we do 12-hour shifts or 10-hour shifts, which are long, we have a lot of interaction during this shift. We have a lot of people that we talk to. We have a lot of emotions during those shifts because we deal with the really difficult patients. And if you look at those two images, for sure, it's an operation unfriendly environment. We do a lot of advances, how to make the ICU better. Nevertheless, it's a noisy environment. It's a bright environment. It's a confusing environment for the users like me. So the question is, how can we make this better? And if you think about the strain, I always like to show those two diagrams. This is actually one of my experiments with the biosensors, which pretty much shows on the left side when I have a normal day at work, which I don't work in the ICU. And the one on the right is the biosensor when I work. And it's clearly visible that when I work, this graph looks very evil. It's very angry. There's a lot of stress. There's a lot of variability. We did a very similar research when we look at our nurses working in the COVID, and you can see that there's a lot of stress, especially when they care about the COVID. So this is the demand. It's not something that we talk about. This is a real fact. Now, this demand comes that I have to make on average 100+ decisions per day. That's a minimum. There was a study done which clearly demonstrated that we make a decision every 2 minutes, and those decisions are complex. And if you think about the complexity of this decision, think how the decision in the ICU or any other medical field happen. We get some input, right? This is the physical data. This is the lab values. We examine the patients. That's a little bit difficult to standardize. We get the imaging with all the interpretation problems. We ask our colleagues to give us their opinions, which sometimes is good, but sometimes it's actually introduced more confusion. And then we use the electronic medical records, which is probably better than the paper record. Nevertheless, this electronic medical record also is prone to the mistakes. Then you have all the environment which works together with you, and then you have all the team, then you have a family, and then you have to be cognizant of all the hospital regulations, state law, federal law, all the issues related to the payment. This is tough, right? This is very, very, very tough. And at the end, you have to make a decision, keeping in mind that you have a certain goals. And what is happening, those decisions are usually made in two ways, either a very logical way, or most of us make the decision quite intuitively. We just get the data together and then we settle on some kind of solution. I'm sure Maya working in the ER know that feeling like this is what we should do. And this decision-making process is a little bit black box. Once we make a decision, we have to spring to action, and and then we have to sort of do the follow-up on the action. Somewhere along that line, we have a stress and we have emotional toll related to that. So again, this is just to show you how tough is this environment. And the question right now is, what can be done about it? So we used to do a lot of strategies aim at improving our task. My favorite one is the introduction of the checklist or the paperwork. So this is a standard ICU running checklist, which it does introduce some homogeneity into the patient care and reduce variability. Nevertheless, it's extra work, and we already stress for work. So what would be the best solution to get us into the place that we have more decision-making power with less effort, so we can focus on the more important things? So one of the things that I sort of focus quite a lot about is quote unquote routine care. So when we go for the rounds, there's a certain things that has to happen to the patients. All the patients should have a DVT prophylaxis. All patients, if they ventilated, should have a VAP bundle. We should talk about the feeding and nutrition. And then we talk a lot about the electrolytes. This is a mantra, which is everyday rounds. And everybody who is in ICU will agree with me that we do this over and over and over. But also everybody who runs in the ICU will agree with me that there's a consistent problem with all those routine orders. Did we truly check whether everybody has a DVT prophylaxis? How much effort did we put in this? How homogeneous are the orders for the feeding and the nutrition? And my favorite that we're going to talk about are the electrolytes orders. And again, all of us who run in the ICU do know that those orders are done in the sometimes very unorthodox or operator-dependent fashion. So this is us as a providers. Now, then you have an AI. Right? And the problem or the benefits of the AI is that the AI never tires. It works and it works and it works and never complains. Not only is the blessing for the management, but it's also a blessing for the patients because you don't have these inconsistencies related to the different cognitive performance of your provider. Once you program AI, it's relatively consistent. Depends what kind of set of the variables you input. The delivery of the care is quite consistent. Some people hold this against the AI as a way to provide the care, sort of standardized, quote, over standardized care to everybody. Well, you can program the AI or you can design the AI engine, which is adaptable. All of this, at the end of the day, will result in the reduced variability. And what I want to do in my presentation is to convince you that actual AI is really good for you because it relieve your activities from doing all these routine tasks to do something that we all trained to do, which is delivering the healthcare, talking to the family, and being a good teammate. So, why electrolytes? Well, let me ask you the question: how effective are the electrolyte replacements? What are the guides that we have to design our action when we repeat the electrolytes? And what are the better ways of doing the electrolyte replacement? And we can have a long and academic discussion, but nevertheless, probably we will not be able to reach the conclusion. Why? Because there is so much variability and the data are not the best. So let's look at the data. So what I did at some point is we actually studied how effective are the electrolyte replacement. And for this particular study, we look what is happening at my institution. And what we look is that a lot of electrolyte replacement happens when you have a normal value for potassium, magnesium. For the phosphate, that's a different game. Well, it's not the singular event. We took also the data from MIMIC, and we look at the same thing. And again, it looks a lot of electrolyte replacement happens when the desired value, or I'm sorry, the pre-existing value is within the reference range. So that will tell you that a lot of replacement is done preemptively. And I can show you more data demonstrating that those electrolyte replacement are not the most effective. They may be preemptive, but how do you judge their effectiveness? And they take a lot of time. So when you think about electrolyte replacement, what would be the better way of doing that? So one thing is maybe you should target the population who can uniquely benefit from the aggressive or more stringent or whatever we define electrolyte replacement. That's a precision medicine. Then maybe we should ask ourselves, maybe patients are not alike. Maybe some patient has a different needs than the other. And the example which goes in the electrolyte replacement is the example of the replacement of the potassium of the people with the renal failure. Should we treat them differently depending on where they are on the dialysis trajectory? If you think about the electrolyte replacement, think how complicated is the process to replace electrolytes. So if this process is done for no clinical benefit, it's a waste. So I have to order, I have to review the pre-existing lab, I have to write the order, a pharmacy has to fill, a nurse has to administer, and then I have to actually follow up with the lab test and review it again. There's small minutes here and there, but at the end of the day, they actually add to the significant burden during the workday. And if you multiply by number of the patient, this is really becoming a little bit time-consuming thing. And if you think also, if you do this incorrectly, there's a huge risk in the electrolyte replacement. They tend to have a narrow range in the terms of the physiology. So what we strive here is to look at the artificial intelligence in order to guide us how to replace the electrolytes. And the way we sort of look at this is very, very simple. We took the data set, we trained the data set using an algorithm, and then we try to reapply this algorithm to the actual actionable electrolyte replacement in the institution. So again, let's go look for some data. So this is what happened when we look at the electrolyte replacement after the implementation of the electrolyte replacement. We're going to talk only about the potassium. And we did put a couple requirements or the requirements on the AI. And one of the requirements, what we did, is that the electrolyte replacement should not happen above the level 3.5. Well, we can question whether 3.5 is the optimal, maybe 3.7 or 4.0. But what you see here right now is that electrolyte replacement does not start, if it's driven by the AI, it's not very scattered. It's much more narrow, and it does not replete at the time when electrolytes should not be repleted above the 4. The other thing is that we actually also try, and this is for all the electrolytes, we look how this AI-driven policy change what kind of electrolytes route is being used. And as you see over here, two things happen. More electrolytes is being repeated in the higher dose, which is the testimony to our repletion strategy, which is most of the time ineffective. And the other thing that we see over here, more and more electrolyte replacement is being done using the oral replacement. And that's actually safer. So we have two immediate benefits of this AI policy. One, we don't replete when the levels are above 4, and probably most of us agree that it's not necessary. Second thing, we reduce the harm by pretty much using the oral way as a way to deliver. So this is a slightly complicated figure, but what it shows is the same sort of shift in the policy when we introduce the AI. And the one thing that I want to kind of point it to you is that if you look at the potassium and magnesium, there's a significant shift in the policy signified by the lack of the symmetry between the green and the red. But if you look at the phosphate, there's not that much of the shift. And if you recall the initial picture, phosphate are mostly repleted when the level is truly low, and the proper repletion is undisputed by most of the physicians. And this is what is happening when we put the system into the action. So you have pretty much on the top screen the level of the potassium measured in the patients. This is the scale is in the hours. And then you have this is the top screen. On the bottom screen, what you see is what happened in the usual situation in terms of the repletion. So the patient received 3 doses of the IV. And as you can see, those doses were done mostly when the patient was within the normal range, and no repletion happened when the patient really dropped, versus when you have an AI-driven policy, that repletion happened when the patient is borderline low, and for sure it happens before when the patient is low. So what we're seeing over here is the situation that the AI can actually quite effectively replete the potassium and potentially intervene even more effectively. So now, all of this sounds like a great story. Well, as Maya pointed out, AI implementation is not easy. There are medical legal issues. There is IP problems related to that. There's a question how much provider and the consumers would like to trust AI-driven protocols, and those are universal issues. The big question that we also ask with this particular project is, what is the value? And the value of the AI can be couple-fold. Obviously, there is a savings in the money. Our repletion rate dropped dramatically. Second thing, we reduce the risk. We do not have a situation when the repletion happened because there's preemptive repletion. We can target the patients much more precisely. But the most important thing, which is for me, and I'm sure my colleagues would thank me for that, I have more time to work on the important stuff. Important stuff means that when my cognitive abilities are more suited than the AI. And that's a lot of clinical decision making that we have to do in the ICU and the ER. And then finally, we have to kind of think about AI in the terms, how do we see the AI in the ICU settings work? Because remember, AI and human being, we complementary. Quite often we think about it that we exclusionary. No, we both make a best team. So how does the AI should work? Should be advisor, should be directive, or should be just the information? So this is all the question, not really much of the answers that I have for you. I would like to thank you, my team, and that's a lot of people from both University of Pennsylvania, Leonard Davis Institute for the Healthcare Economics, or the Princeton. And if there's any question, I would like to open the floor and come back to Maya. Thank you very much.
All right. Thank you everyone for joining us today. We're going to complete this session and we'll be moving on to the one-on-one networking break, but be sure to return for the final plenary session to complete our day.